Good day, everyone. I hope everyone can hear me well. Welcome to this first community talk of 2023. We're very happy to welcome you all. We're very pleased to introduce you to Nathalia Lourenço and Patrick Luyten. Nathalia completed her PhD under the supervision of Dr. Bulelwa, Nosilela, and Professor Patrick Luyten. This research was conducted within the VLIR-UOS TEAMS framework with cooperation between KU Leuven in Belgium and Rhodes University in South Africa. We're very excited to learn about this research journey and to gain insight on filling the language gap between using communication resources for HIV/AIDS and tuberculosis healthcare in South Africa. After the presentation, there will be a Q&A, so feel free to already post your questions in this chat. Dr. Lourenço and Professor Luyten, the floor is all yours.
Thank you so much, Laura, and a very warm welcome on my behalf to everyone. And it's a real pleasure and delight to introduce this session. I will take only 2 minutes or so to do that, to give Nathalia maximum time to present the research and findings and for the discussion. The starting point of this study was fairly simple and obvious, if you like. On the one hand, it's South Africa has about 11 official languages, but on the other hand, what we see is that many health professionals have no command of many of these languages, and this is a real and pressing issue, particularly in care for patients with HIV and tuberculosis. South Africa has, unfortunately, the highest prevalence of people with HIV, and HIV is also highly comorbid with tuberculosis. So in care for these individuals, there's often a very large, considerable language gap. And this struck us, and this is what we wanted to address in a multidisciplinary and interdisciplinary research in South Africa. So we launched a series of studies looking at the needs and concerns of health professionals concerning language issues in South Africa, in healthcare workers caring for individuals with HIV and tuberculosis. We also did small pilot studies, piloting resources, communication materials, and so on. And then we did a pilot feasibility trial. So we tested the effectiveness, but also acceptability and feasibility of communication resources in South African healthcare. And this is what I believe Nathalia is going to focus on. And she's also going to talk a little bit about how we can begin to implement these new resources in South African healthcare, but also in medical education. So again, incredible honor and delight to hand over at this time to Nathalia to present some of the main findings. There's many others, but some of the main findings of her PhD research. And this would also be a very good opportunity to acknowledge the support of many of this study. Of course, my colleagues who supervise with me, Dr. Bulelwa Nosilela, and in the early stage also Russell Kashula, who's now at the University of the Western Cape in South Africa, but also a whole team of other people, both in South Africa and in Belgium. And finally, before I finally hand over to Nathalia, this is again also an excellent opportunity to thank VLIR-UOS, not only for their funding, but also for their unwavering support in often very difficult circumstances amidst the COVID crisis. So handing it over now to you, Nathalia.
Thank you very much, Prof. Luyten, for the introduction, and thank you to Laura as well. And thank you to VLIR-UOS for having us this morning. I'm going to share my screen, not this one. Yeah. You can see my presentation? Great.
Yeah.
All right, so my name is Nathalia Lourenço, and as has been mentioned, I will be presenting on filling the language gap using communication resources for HIV/AIDS and tuberculosis healthcare in South Africa. What I will speak about today is a broad introduction to healthcare communication in South Africa, focusing particularly on HIV/AIDS and tuberculosis. I will introduce the research questions and objectives of the PhD broadly, but also what I will be focusing on in this presentation. I will present to you the Healthy Talk intervention, which is the resources and training materials that we put together for this study. I will share some of the key findings from our study, particularly from the pilot feasibility trial, and then I will share some conclusions and recommendations. As Prof Luyten has already mentioned, South Africa has the largest number of people living with HIV in the world. It has the third highest TB rate globally and the second highest rate of multi-drug resistant TB globally, which also has increased prevalence due to people not taking their medication as prescribed or stopping taking their medication, which can also be traced in certain cases to lack of communication and communication across language barriers. South Africa also is a very unequal country. So this photograph, which was taken in South Africa, it was the cover of Time magazine in 2019 with the headline, "The World's Most Unequal Country." So inequalities pervade South African society on many different levels, in many different ways. So this shows an informal settlement on the one side and across the road, a suburb in Gauteng province. And we know also from latest World Bank reports that South Africa still remains the most unequal country in the world. One of the many factors contributing to this inequality is communication and language, language and communication. So Penn and Watermeyer have said that communication has been identified as the single biggest barrier to healthcare in a global world. What does this mean and what does this look like? So basically, South Africa has 11 official languages and many more languages that are spoken but not official languages. And it has been estimated that up to 80% of healthcare consultations are conducted across language barriers. So here we can see home languages and languages spoken outside the home in South Africa. And it shows us that even though only 8% of South Africans speak English as their home language, double that number commonly use English for communication outside of their homes. Many South Africans are multilingual and therefore speak more languages other than their primary home language. But what this also means is, even though multilingualism is common in South Africa, it's more prevalent in certain locations or contexts. So for example, in urban areas, whereas people in rural areas or in more linguistically homogeneous provinces might only speak their home language. However, English is a language that is commonly used in more official settings, but not everyone is proficient in English. And what this means in healthcare is that in cases where healthcare professionals do not speak the language in which the healthcare user is fluent, then healthcare users' understanding of their health and their agency in their health is limited. So to address this, we put together the following research questions, which was firstly looking at how do healthcare providers and healthcare users communicate when they are not fluent in the same language. Secondly, what communication resources and training are appropriate for healthcare provision in South Africa. Thirdly, what are the effects of the suggested communication resources and training? And fourth, how feasible is it to implement and measure these resources and training? Today, I will briefly touch on some things from 1 and 2, but I will be mostly focusing on the effects of the communication resources and feasibility of this. The objectives to answer these questions was firstly to identify the main communication problems experienced by healthcare providers and healthcare users, and to identify the strategies that they used to bridge these gaps. Third, to create and implement communication resources and training for healthcare providers to use, particularly for HIV/AIDS and TB consultations. And fourth, to analyze the effects of these communication resources and training in terms of satisfaction and feasibility of implementation. So again, I'll be focusing mostly on the objectives 3 and 4. How we set this up was in part at the beginning, very much focused using a participatory action research design, in which we did 2 needs analyses with healthcare professionals to find out what are the communication problems that they face and how do they deal with them. And then also to work with healthcare professionals to identify and create and adapt resources that were aimed at improving healthcare communication in HIV/AIDS and TB. So using this, we put together a resource pack, after which we implemented a cluster randomized waitlist controlled pilot feasibility trial. And this was to look at the feasibility and efficacy of the resources and training to improve healthcare communication for HIV/AIDS and TB. This was with hospitals and healthcare NGOs in the Eastern Cape province of South Africa. We worked with 6 sites. 4 of them were hospitals and 2 of them were healthcare NGOs. And for this, the feasibility was considered in terms of the recruitment of sites. So how easy or difficult was it to recruit sites? And once we had the sites, the recruitment of the healthcare professionals at those sites. Thirdly, the healthcare professionals' participation in the research, which involved answering questionnaires at the beginning, middle, and end. Participating in a feedback group on WhatsApp after 1 month of using the resources, and participating in interviews at the end of the research after 2 months of using the resources. And then satisfaction was considered in terms of the participants' self-reported use of the proposed resources and the qualitative feedback that we received from the WhatsApp feedback group and interviews. I would just like to mention a few limitations of the pilot feasibility trial. The first is that in COVID, we ended up not being able to include healthcare users in this research, which of course is but once we started with the research and then COVID meant we were not able to release
Someone who needs to mute my.
Thank you. Thank you very much. The exclusion of the healthcare users due to COVID is of course a limitation. Another limitation that we had, which was a benefit in other ways, but because we used the participatory action research, including in the methodology, so we included the participants' ideas in the methods that we use to collect data and how we set things up, including timelines and so on. So the healthcare professionals played a really important role in this, which we're very pleased about. But this also meant that we had different methods and different formats of the data that we collected. So it just made it a bit more complex to compare across the different groups. And then the third limitation was that we did have a small sample size of participating healthcare professionals. Some of the initial research findings after the needs analyses at the beginning, so this was really from the participatory action research phase, I would just like to share a couple that I think were interesting and that shaped what we did next. Firstly we saw with the participating healthcare professionals, when they were speaking about their communication in their healthcare consultations, there was 2 dominant ways of thinking about communication. On the one hand, some healthcare professionals focused on the healthcare users' inability to speak English. So the healthcare professional spoke English and then noted that someone couldn't speak English to them. whereas the others focused on their own inability to speak the home language of the healthcare user. For example, some of the healthcare professionals said that communication barriers were there because patients didn't understand, and some of their suggestions to address this was to teach patients English at school. On the other hand, we had some healthcare professionals who really focused on their inabilities to speak the home language of the healthcare user. For example, someone said that they had learned a handful of terms commonly used in counseling the patient. For example, take one tablet 3 times a day. Made a list of very basic translations that they used during counseling. And because they struggled with pronunciation of some of the words, they would also show this list of translations to the healthcare user to show what they were trying to say. Next. So not only were, you can hear me now, yeah?
Yeah, we can.
So not only was this person aware of their inability to speak the healthcare user's home language, they were also taking steps to address this. Some of the other findings that we had at the beginning from the needs analyses and then from speaking with the healthcare professionals about what resources they would like to use, we also found that they did not want or expect resources that were a one-size-fits-all kind of resource. So with this, they noted how different types of resources were needed for different topics. So for example, with presenting information, they would be very happy to use a resource like a poster or something that is just like a static resource, I guess, compared to counseling where they wanted something that would facilitate conversation, and then compared to reinforcing information where they felt that something like a pamphlet would be useful. They also noted the difference between resources needed by hospitals compared to clinics. So in the South African context, there are many more. Clinics are the primary healthcare facility where people will first go, and then not as many people go to hospitals. And clinics usually, the healthcare professionals working at clinics are usually nurses who often share the home language and culture of the healthcare users, compared to hospitals where there are, of course, still nurses, but also doctors who do not share often do not speak the local language of the province. So maybe they speak another English usually, and then also another South African language possibly, or another African language or another language from their home country. But we definitely see a lot more language barriers at hospitals. So of course, the types of resources that would be needed by hospitals differed to those from clinics. The healthcare professionals also noted the importance of the healthcare user's background, in particular their literacy levels. So for example, if they could read and write or not, that would affect whether the healthcare professionals would give them a pamphlet, for example. And they also noted people's comfort with using digital media. And this was because we had also spoken about using digital resources like a translation app and whether they felt that would be appropriate in their consultations. And they noted that with younger healthcare users that this would be possible, but there was some hesitancy with using digital media for the older healthcare users, and that there might be some resistance to including technology in their consultations. They also noted the practicalities of the resources. So for example, someone noted that she worked across different sites. So she wasn't going to take a poster with her from one site to another and keep sticking it on the wall. And that she also noted that it needed to be a size that would be easy for her to put in her bag and take with her. And something that was really important across this was that the healthcare professionals wanted something that was interactive. So whether that meant interactive that would facilitate conversation, or something that, for example, if they're drawing a diagram and speaking about it with the healthcare user, or they also gave the example of a video that was played in the waiting room, and that would then prompt conversation when the healthcare user came to the consultation. So yeah, the interaction was also very important. Taking all of this into account, we then put together what we called the Healthy Talk intervention. So this was a resource pack that had 3 types of resources. It had flashcards, digital flashcards, and a translation app. And then it also had a training manual that explained how to use the resources. So the flashcards we created using pictograms that had already been developed specifically for the South African context. So these pictograms had already been used in pamphlets and posters, but this was the first time that they have been used in flashcards. So they already existed and were used mostly in studies around pharmacy. And as I mentioned, they'd been developed specifically, not just specifically for the South African context, but they had already been tested in the Eastern Cape context, which is the province in which we were working. So these, we made them so that they could easily fit in your hand and you could flip through them, and you could put them in an order that worked for what you wanted to say. And they were then also available in a digital format in a PDF that you could use on your phone. So if you didn't have the flashcards with you, you could scroll through to get them on your phone. They had the pictogram on them, and then underneath they had the word or phrase in English and the translation in isiXhosa, which is the language most commonly spoken in the Eastern Cape province. So we had the flashcards and the digital ones. Then the third resource was the Aways the Med healthcare app. So this is also an app that already existed and had been developed specifically for the South African healthcare context. So we know that Google Translate is very inaccurate for healthcare and particularly for African languages. So this one it's a translation app. You can click on the sentence and it will speak the sentence out loud in any of the South African languages. But the sentences and phrases are all specific to healthcare, and they include a section on HIV/AIDS and tuberculosis. To guide the participating healthcare professionals on how to use it, they also received a training manual that explained how to use the resources and provided some ideas to practice using them. So again, because of COVID, we had planned and then we unplanned to have in-person training sessions. And most of this was then put into the training manual that would guide people. They also received a small USB flash stick that had some videos that gave examples of how to use the resources, and also had some of the resources to the digital flashcards resource to download. Some of the findings from the pilot feasibility study when we implemented the Healthy Talk intervention was firstly that we found a lot around the healthcare professionals' perspectives. So in the literature, we often find about the negative effect of language barriers on healthcare users from the healthcare users' perspective. Of course, we do also find literature on healthcare professionals' perspectives too, but this study provided more insights into this. So for example, an intern at Lindiwe Sidali Hospital, the hospital's names have all been changed for this, this intern found that the language barrier is detrimental to both the healthcare user and healthcare professional, just like the consultation, but also the patient's health, as well as the way they approach the patient. They find that when they can't communicate with the patient properly, they get very frustrated and they'll just go get a translator. So they noted how the language barriers impacted how they felt, but also how their feelings, because of the language barrier, then impacted the consultation and the quality of healthcare that the healthcare user was receiving. We also found with interpreting that most healthcare centers rely on ad hoc interpreting by informal interpreters. So this is already a finding in the literature, and that informal interpreters could include nurses, other healthcare center staff, but also people's family, other patients, and so on. So this is found in the literature, but this was also reported across both the needs analyses and in the pilot feasibility study. And what was interesting with this was the difference we saw across the different sites. So in some cases, in most cases, it was very common for healthcare professionals who didn't speak isiXhosa to find people to interpret often. And indeed, it was never with trained interpreters. But in some cases, at some sites, it was much easier than at other sites. So at some sites, people, even when they had the resources, preferred to still work with an interpreter because they already had established ways of working, and people were it was easy enough to find someone to interpret. Whereas at other sites, some of the healthcare professionals reported that it would take them up to 20 minutes to find an interpreter while they had a healthcare user waiting for them. And in other cases, they also reported the negative impact that it had on their professional relationships. So some of them noted that they didn't want to ask some of the nurses to interpret because, of course, the nurses already have their nursing jobs, and taking them away from that had a negative impact on their interpersonal relationships. So, for example, this was from the WhatsApp feedback group, that one of the healthcare professionals noted that the busier it gets at work, the less likely they were to use the resources, especially in the setting of a busy clinic with lots of patients waiting. They were more likely to call someone to help translate because it's quicker than trying to use the resources. So this feedback was given after 1 month of trying out the resources. Another person said that lots of things are lost in translation. You can't get your points across, or often I'll say this whole long thing and the translator will say 2 words, and then surely that's not what I asked. So this also speaks to the frustration a lot of healthcare professionals experience with interpreting and working with informal ad hoc interpreters. Yeah, like I mentioned, that it was quite different across the different sites, and this person who was an intern at the one hospital said that they found everyone had quite a different experience, depending obviously on where you are and where you're working, in terms of working in an outpatient department setting versus working casualty setting versus a ward, in terms of how quickly you have to move, what kind of patients you're exposed to, if you have translators around, or if you have to just push yourself, or if it's easier to just ask someone who knows. So yeah, this speaks again to what I was saying about whether people had other people readily available to help with interpreting, and this often influenced their choice of whether or not to use the resources. On the other hand, one of the doctors at Nosilela Hospital said that they've still found it, this is again after 1 month of using the resources in the WhatsApp chat, they said that it's still tricky at this stage for them to arrange the flashcards the best, and sometimes they have this overwhelming feeling of having to push the queue. They find that they're practicing with paternalistic medicine returns, and one just writes plans and hopes that someone explains it to the healthcare user. They mentioned that they really don't like working like that, but they felt that the flashcards, given time and more practice, would really help with breaking down the paternalistic medicine model, and he hopes he can get better at using them. So this showed us that even though in this case for this person, they were not yet that comfortable with using the flashcards, and it was still taking more time than they sometimes had in their consultations, that eventually they would like to be working with them more. We asked the healthcare professionals in the intervention group how often they use the resources, and we found that by T3, which was after 2 months, most participants were using the printed flashcards, and they were using these around once a week. They were using the digital flashcards once a week or less, and very few participants were actually using the translation app. But those that did use it, used it once or several times a week. We also had a questionnaire with both the intervention and control group, where we asked questions on communication and trust and resources. So we asked them to rate from 1 to 5 whether they were able to communicate effectively with the patient, if the patient is able to communicate effectively with them, if they felt they had the resources they needed to communicate in that consultation, if they felt the relationship between them and the patient is good, and if they felt that the patient trusts the advice and treatment that they give them. So for this, we found many differences between the control group and the intervention group. And we believe this was mostly due to having a small number of participants in the control group and several of them also falling off by T3. But when we looked at the mean of the scale in the intervention group, the improvement from T1 before they received the resources to T3 we saw was almost but not quite statistically significant. To account for the participant dropout, we also looked at linear mixed models, and this generally reflected the results of the ANOVA. But what was of interest was when we looked at each question individually, the one that stood out was question 3, which was about, I have the resources I need to communicate effectively in this consultation with this patient. For this one, there was a significant and very significant effect of time on the intervention group between T1 and T2. So from before they received the resources to after 1 month, and from before they received the resources and after 2 months. So you can see that they were answering, the mean was sitting around 3 out of 5 in terms of feeling they had the resources they needed. But by the time after you having the resources for 2 months, this moved up to almost 4. Again, we had very small numbers, and these are just preliminary findings. It was a pilot feasibility study, but this is something that we would also suggest investigating further in something like a randomized control trial. One of the interesting findings that we had about with the resources in the pilot feasibility trial was the preference for language learning. So, for example, a dietitian at Nosilela Hospital said that he often found himself using the flashcards to learn the phrase or word in isiXhosa, and he referred to this as off-label use or using something not in the way that it was suggested or prescribed. So even though we had spoken with healthcare professionals before while we were putting together the intervention pack, at that point there wasn't such a big expressed desire for language learning. But when we gave these healthcare professionals the resources that we had put together, we saw that they found ways to use it for language learning. So the feedback that we received from the healthcare professionals reflected a common experience of healthcare professionals who would like to learn isiXhosa at their place of work, but hadn't been granted the opportunity to do so in a more formalized setting. So, for example, the dietitian who I just quoted, he had been requesting isiXhosa lessons for the 9 years that he had been working there. So every year in their staff feedback, he would request lessons, and they still didn't have isiXhosa lessons for staff. And then at Lindiwe Sidali Hospital, there was both an intern and an occupational therapist that mentioned that they mostly used the flashcards to refer to themselves. So we had created the flashcards with the intention of them being interactive in terms of the healthcare professional showing the healthcare use of the flashcards and using either reading or using the translations or showing the translations, that they would be patient facing. But we saw with some of the healthcare professionals that they were rather using them themselves as a language learning tool, sort of like a language learning device or a glossary, rather than props or, like I mentioned, not really using them so much as healthcare user facing. So considering this, some of the suggestions that we have for further research would firstly, and this maybe sounds like a bit of an obvious one, but would be firstly to employ an in-person or blended approach to the research. But why I'm including this as a recommendation is because I mentioned some of the impact that COVID had on this research, which meant that what was planned to be a very hands-on in-person research project ended up being a lot more online. But I think in the South African context, this is something that is important to explore because a lot of sites that we would like to include in research are often quite difficult to reach for various reasons. And also access to internet is also not always available. So we can't rely completely on online research either. But what we found worked quite well, I think, was to have at least the initial meeting with people in person, so that, you know, we would even trying to contact the sites by phone or email when we were not allowed to visit them. That was very difficult, but once we could actually go in person just to get things set up, and then to meet the potential participants and clarify who would be participating and then meet them in person. Once we had done that, it was then easier to keep in touch with them, and we did this mostly via WhatsApp because WhatsApp is still quite accessible in South Africa. And this meant that this could mean that it's not necessary to always be visiting sites if you have really good relationships set up at the beginning and you can keep in touch via WhatsApp. But of course, if we can be there in person, it is better. Secondly, a recommendation is to build an awareness of the role of communication. So as I mentioned at the beginning, some healthcare professionals expressed that they felt the communication was something that was the healthcare user's responsibility or something that they didn't really think about. And we think that for the successful implementation of communication resources, it's important, or even the successful recruitment of participants, it's important to first build an awareness of the role of communication in healthcare, to clarify what it is, to help people to be aware of it, not just as something that is the healthcare user's responsibility, but that is something that both the healthcare user and healthcare professional engage in the consultations. The third recommendation would be to reflect the participant's agency through flexible resources. So when, speaking from a personal perspective, I guess, when I began this research, I began with the idea that we need something that is easy. That was, I guess, sort of the main thing I was focusing on. And language learning is certainly not something that is easy. It's something that is a long-term investment. So I hadn't thought that much about language learning resources. I had really focused on, it needs to be something that is quick and easy to implement, and then people will use it. Which, looking back on it, it's clear that this was a overly simplistic view. So yeah, we realized the importance of the flexibility of resources, because I think that whatever the resources people receive are, they're going to make them their own and use them in ways that are most suitable for their context. So I gave the example already of the healthcare professionals who were using the resources for language learning. Another example is one of the doctors really liked the flashcards, but she also wanted to have pamphlets for the healthcare users to take home. So what she wanted to do was to take the flashcard pictograms and translations, put them on a page together and photocopy them into booklets that either she could refer to, or they could share a booklet among the ward, or they could be taken home by the healthcare users. So yeah, also because with this study, the people who participated were already sensitized to the to health communication issues. I think that's also why we saw a lot of investment from some of the participants in using the resources in a way that worked for them, because they were already investing their time and energy into improving their communication. Yeah. Then recommendations for when considering higher education institutions in South Africa. So South African higher education institutions, they have already taken great steps to include communication as part of healthcare degrees, because language courses are included in healthcare degrees. So these are important, of course, in terms of learning a language, but also they are important in sensitizing healthcare professionals in training to the importance of communication. However, as we know, 1 year of a language course doesn't quite prepare someone to use a language fluently in clinical practice. And also what often happens in South Africa is people might study their healthcare degree in one province and learn one language, and then end up working in a different province in a language that they hadn't learned, which was the case with one of the healthcare professionals in the study. So therefore, we would suggest that within these courses in higher education institutions, it includes not just the language learning element, but also strategies and resources that healthcare professionals could use themselves to adapt to whichever language community they might end up working in. So again, speaking back to the flexibility of resources and including the skills and knowledge to use something like that. Then in terms of continuing medical education in healthcare centers, we know that the healthcare professionals' desire for language learning support at the workplace, this isn't a new finding, especially in South Africa, but it was interesting to see what this desire looks like when healthcare professionals are presented with other opportunities to improve their communication. So teaching hospitals and all healthcare sites that include continuing medical education, they could incorporate communications training. So even though language classes would require regular lessons, which I think would take a bit longer to implement, many of the healthcare professionals who are already sensitized to health communication issues, they're already taking on the extra work themselves. So including a couple of lessons on health communication tools would then better equip them for the work that they're already doing on their own. But finally, I did just want to note that even though we are suggesting resources and training and the sort of easy to implement strategies, that this shouldn't be seen in any way as a fixing everything for language barriers. It is still really important that the burden of communication is alleviated from healthcare users, and that in order to do so, healthcare professionals do need to receive support in learning the local language of the communities in which they work. That's the end of my presentation. Thank you very much for your time and attention. Again, a very big thank you to VLIR-UOS for your support throughout my PhD journey. And I'm looking forward to speaking with all of you now. Thank you very much.
Excellent. Thank you so much, Nathalia. If there's any questions, I saw a few in the chat, but if you have other questions or comments or suggestions, please feel free. There's one, Nathalia. Will you publish this and will you have to share the research or allow for dissemination among healthcare professionals, more general? I think we have a solid plan to do that.
Yeah, we do. And that's the question is also from Prof. Kashila, who was my supervisor at the beginning, together with Prof. Luyten. So it's very nice to see you here, Prof. Kashila. Yeah, we definitely are planning to share this work in as many, as many different ways as possible. So of course, with it being a PhD study, we are looking at publishing and all of the normal, I guess, ways of sharing the work. In terms of the resources, these are available, or they will be available on the Healthy Talk website. We are just making a few final adjustments based on the feedback that we received, and then these will be freely available for healthcare professionals to use. And then we would also like to be publishing in more I guess, popular press, particularly in South Africa, because they can be adjusted for many different contexts, but our focus was South Africa and the Eastern Cape. So we already know some of the popular press, for example, The Conversation, and some of the more local newspapers and so on. And then, of course, sharing this with the healthcare professionals who we worked with, because this really came together because of them and their insights and the work that we did together with them. So I think already that speaks to their investment in using it and hopefully in sharing it as well. Because again, it's something that, if you hear about it, in fact, even one of the doctors had seen the pictograms before. So when I was showing her the resources, she said she had read about them in the research that had been published on it. But she'd read the research, but of course not then taken the pictograms to use them herself, because it was research. It wasn't geared to be used immediately in a hospital. So we do want to make this available in ways that it can just be used in hospital settings. That's also why we have the training manual that's already, you can just read the training manual and know how to use the resources. So we want to work together with the sites to implement it from the ground up and hopefully spread it further in this way as well.
Any other questions or remarks? Have a look at the chat yourself, Nathalia, if you can. Yeah. But the last one is still relevant. I think you answered that, and that we will make them available through the website, but also be furthering develop them.
Yeah. So the website, out of interest, it's healthytalk.co.za, but they're not on the website just yet, but it will be there. I see there's also a question of, will we research this from the patient's perspective? So this is definitely something that does need to be done and that we had planned to do. Speaking for myself personally, I'm not sure what happens next exactly in terms of research because I've just finished with my PhD, but this is something that I have also been speaking with Dr. Nosilela at the African Language Studies Department at Rhodes, and also Prof. Dowes at the Pharmacy Department at Rhodes, who developed the pictograms, thinking around how can this be taken further for further research, perhaps with more master students or further PhDs, to be looking more at the resources and indeed from including the patient's perspective, because it is something that, if it weren't for COVID, would be here and something that is really important to look at. So thank you, Alison, for that question.
There's also a very interesting question, a remark actually on the right of an individual to use her or his mother tongue. I think it's very interesting comment and suggestion.
Yeah. This is a very important comment as well. So South Africa, we have really fantastic language rights on paper. So as we have the 11 official languages, and we have also a lot of policies that say exactly this, that people have the right to use their home language, particularly the language of the province. So the Eastern Cape, the province in which we worked, the main languages there are English, or isiXhosa mostly, Afrikaans and English. So in theory, people do have the right to access healthcare and healthcare information in this language. But the difficulty is that even though people have the rights on paper, there are not necessarily those practicalities in place. So this is really actually a big motivation for this research, was exactly this mismatch between people's rights on paper and what is possible. So, of course, having more support for language learning would address this, but also having something that could be implemented like this could hopefully address that as well. And then also the second part of the question was just taking into account the mastery of a second language decreases in stressful situations such as illness. This was also something that was mentioned by the healthcare professionals, was already even in your first language, if you receive a new diagnosis in your home language, that people will often forget whatever information comes next because it's a very stressful situation. So as you've mentioned here, the second language, this is even increased. This is also why the pamphlets were something that a few people did recommend including, because it's something that people could refer to afterwards after either not having understood or not taken in the information in that situation.
And indeed, I think we try to formulate a number of recommendations and guidelines for the future of medical education, with a much greater emphasis on the language gap and on language in general. So if anyone is interested, we would be happy to forward them to you. If this study can contribute anything to changes in in how health professionals are educated about language, we would be delighted.
Yeah.
And indeed, it's the well-known gap between policy and practice. But there is a solid basis. I mean, it's in the law. Yeah. Yeah. And this is an open invitation. Yeah. Indeed, we are looking for educational medical stuff. Yeah, we are looking in ways how to continue this line of research, of course, because now we have laid a very solid groundwork.
Also noting the question in the chat about the language learning of healthcare professionals compared to healthcare users, and about healthcare providers are in general more capable of learning languages than their patients. Have we found something about this perspective in the literature? Are health providers willing to put in this effort? So something that that comes up a lot in the literature and that we also saw in this study is, particularly in the South African context, I think this we see a lot globally as well, but particularly in the South African context, language prestige played such a big role. So English holds a lot of prestige, and it's seen as a language for healthcare, whereas African languages, particularly in the South African context, where the apartheid government did a lot of work to make African languages seen as something that is only for the home and that does not, that could not be used in medical settings, for example. There's still quite a lot of beliefs pervading the South African healthcare context that English is the language of healthcare. So even though healthcare providers often do have more opportunities to learn the language of their patients than the other way around, there are still these barriers in place where people think, but it's English. So I think that if the languages were different, if we were in a different context where the prestige of the different languages was reversed or something, then it would be different. But here it really is something why the question of, are healthcare providers willing to put in this effort? Yes, we saw some of them are, because they participated in the study and were already doing so, but that certainly doesn't speak to all of them. So addressing the inequality of prestige in languages is something that is, I think, a very important thing to consider in approaching this.
I propose we address one more question before closing.
Yeah, there's an interesting one on materials for patients' use. Nathalia, you will have to do another PhD.
Yeah, it's something that I'm again also very interested in. And what we had also thought of and had discussed a bit with the healthcare professionals is not just, so obviously here we didn't have access to the healthcare users, so we couldn't work with them to create materials, but with speaking with the healthcare professionals, in some of the conversations we had around how interactive the resources were, this did sort of come up that they wanted something that they could, while they're explaining, they could draw a picture or whatever, but to have something, this sort of led us to speaking about something that is for patients' use together with the healthcare professional in the consultation. So for example, if they're giving information that is something that they could draw together or fill in together, that the one healthcare professional used the example of, he always would draw, there was some diagram that he always drew, and that it just looks like a scribble if he doesn't explain it, but that at the end of the consultation, he would often have healthcare users ask him, can I take this drawing home with me so that I can remember or explain? So that was something we really did want to, that we would want to look into further when we could have the insights from healthcare users, something that could be, of course, interested also in stuff specifically for the healthcare users, but something that could be worked on together, whether it's just techniques for how to do collaborative diagrams or something more like that, but something that could be worked on together in consultations and taken home. Those are just the beginning thoughts at the moment.
Yeah. Good. Excellent. I see it's 12 noon, so we probably unfortunately need to stop. I see there's still other questions. So again, thank you so much for attending this presentation. Laura, perhaps you want to say some final words?
Yes, and first and foremost, I would like to thank you, Professor Luyten and Dr. Lourenço, for sharing this, your research project and findings with us. It was a real pleasure to have you on our community talk. I wish you also good luck with your on your next research project, as the questions indicated. This was very interesting, and people are waiting for a follow-up. On a more practical note, this presentation has been recorded and can soon also be watched or rewatched through our website. The link will be shared in the chat. And also for the audience, thank you for your presence, for your comments and questions. We'll also like to inform you on our next community talk that will take place on Wednesday, March 29th. And it will be in spirit of the International Women's Day. And the topic will be improving women's health in Peru with the support of higher education institutions, women and local governments. I will receive an invitation and subscription link soon. So we hope to see you all then. We wish you all a lovely afternoon.
Okay. Thank you so much. Bye-bye.
Thank you, everyone. Bye.
Bye.